Welcome to AFSPA Talks, a production of the American Foreign Service Protective Association. Each week, we deliver informative health and wellness topics you want to know about, so be sure to subscribe to us on your favorite podcast channel. And if you have any questions about content discussed in this episode, ask them at AFSPA Live, our live Q&A session, streaming every last Thursday of the month at 11 a.m. Eastern Time on youtube.com/AFSPAcares. Now here's your host, Chief Operating Officer Kyle Longton.
Hi, and welcome to another episode of AFSPA Talks. I'm your host, Kyle Longton, and it's been a little while since I've been with you, and I'm sorry about that. We've been working on getting some episodes and some things. Took a little while longer than I had anticipated to come together, both for me and sometimes for our guests, but I promise today's episode will have been worth the wait. I had a great time, but before we get to that, I just want to give you a heads up about a few things that you can find on our website, and particularly on our YouTube page now, youtube.com/AFSPAcares. You can find a recording of our annual meeting, which took place on March 3rd. So you can go back and take a look at that. We had guests from Hinge Health there, as well as from Aetna, to talk about some of the programs. Our CEO, Paula Jacob, who's been a frequent guest on this program, gave an overview of 2022 and a look ahead at 2023 and beyond. So I encourage you to go back and take a look at that. You can watch it. It is a couple hours long, so you may want to take it in pieces, but that's okay. That's the beauty of the video. The other thing that you can catch now that just happened last week, as this episode is coming to you the first Monday in April. Last week we did our AFSPA Live with a focus on telehealth. So particularly our partners at Teladoc and vHealth for stateside and overseas telehealth care, respectively. And we did have a few questions come in that didn't focus specific on that topic, but we did keep the conversation there, along with a guest from Teladoc, to talk about some of the programs and how you, our FSBP members and others, have been using the program. So take a listen to that. Again, you can find that on our YouTube page with the video and the audio, of course. So however you wish to approach that. Let's switch then to today's topic. And we had some internal debate about whether to do this topic and how to approach it and so forth. But I thought it was worth noting that with the passage now of March into April of 2023, we've marked 3 years since the COVID-19 pandemic came into and affected most of our lives. It started earlier than that for some, and the dominoes did fall over the course of a few weeks here in the United States as things changed. I'm not going to spend a lot of time in my intro or even throughout the episode talking about how that changed our day-to-day lives and the switch to working remotely and some of the isolation that came for people. We've explored that in other episodes. We may even have an episode coming up focused on the ongoing mental health effects of COVID-19 and just mental health in general in the United States. But for now, I had some questions about generally what's changed over the last 3 years when it comes to public health and healthcare generally. What's the same? How has it changed, domestically in the U.S., with our partners in North America and around the world, and what all this means going forward? What does the future look like? So this is not maybe our typical episode. This is more of a deep dive and a look at what has been the last 3 years and what we've learned from that as a healthcare industry, as I discussed with our guests, whether we're patients or healthcare consumers, exactly what the right word is. It may be something in between of those two. It may be something completely different that we settle on in 5 years from now. But how have things changed for us? And with a particular focus on virtual care, whatever form that may take, and whether that's remote monitoring, whether that's engaging with someone through Teladoc, whether it's talking with your longtime provider, but having that appointment over a virtual platform rather than in person. That has changed for many, if not most of us. And I wanted to use today's episode to understand more about that. And I connected with somebody last year who seemed like a great fit, if not the perfect fit, for our discussion on that. And I was glad that we could come together again this year and bring this episode to you. So this is going to be a longer episode. I encourage you to settle in. Again, we won't be reliving some of the challenges of the early days in minute detail, anything like that, but it is a look at sort of how healthcare has changed. And we're looking at that with Dr. Timothy Foggin. He was very kind to go through some of his background with me in the episode, but I do want to give you his official bio in case we missed any of it when we actually did the recording of the interview. Dr. Timothy Foggin joined Teladoc Health Canada leadership in 2020. Starting his medical career in family medicine, he later branched into travel medicine, public health, and healthcare management, while simultaneously broadening from urban and rural regions of Canada to a more global reach, including work in China and Southeast Asia. Following several years in health emergency management and medical assistance leadership across North Asia, he co-founded the Asia Pacific division of Advanced Medical in 2015. Advanced Medical is now part of Teladoc Health. At Advanced Medical, he built up regional medical teams, clinical operations, product development, and business. Throughout his 10 years in China, he maintained academic affiliations with UBC's School of Population and Public Health, as well as the Ottawa-Shanghai Joint School of Medicine, through which he taught medical humanities to eager undergraduate students. Dr. Foggin is a fellow of the College of Family Physicians, the Royal College of Physicians of Canada, that's FRCPC, Public Health and Preventive Medicine, the American College of Healthcare Executives, FACHE, and diplomat of American and International Boards of Lifestyle Medicine. He references all parts of his qualifications in our interview. Now, his professional passion is working at the interface of population health, primary care, health systems innovation, digital health, and lifestyle medicine. All of that is why I thought he might be the perfect person to talk through this topic with us. He joined me for the interview where he lives, works, and plays from British Columbia, Canada. So, Dr. Foggin, welcome to AFSPA Talks.
Thank you so much. Nice to be here with you, Kyle.
And I provided a brief overview of your biography at the top of the episode, but I wanted to give our listeners a bit more insight into your background that will demonstrate exactly why you're the best person for this episode as we look at COVID-19 3 years on. So, first of all, you have a background in public health. We have heard, particularly in the last 3 years, a lot about public health and public health experts and so forth, but what does that actually mean when we use the term?
Sure. Saying best person is a bit strong a word, but happy to share a bit about public health first. I mean, public health is an area, it's a way of looking at health in terms of medical training. It's a 5-year training like many other, most other specialties. You can have clinical genetics, looking at the the most microscopic level, if you will. You could have cardiology at the organs, pediatrics at the whole person. Public health is looking at health from a population level primarily. And if you look at it from a direct level, say local, this is, health promotion in schools or health protection through restaurants. It will also be, long-term facilities when there are outbreaks. And here we're kind of now verging more on what most are familiar with public health, infectious diseases, which is a component, only a component, albeit a very important one, and more at a global level. When you look at public health, then it will be a question of emerging infectious diseases and watching for them and tracking them and preparing for them. Non-communicable diseases, can't forget those, not just the bugs, and injury prevention fits therein as well. That's a broad, categorization of subsets that hopefully gives a sense of how wide public health is. Wasn't really known as a profession, if you can say it that way, broadly prior to the pandemic. A lot of awareness has come, yet it goes much more than infectious diseases.
I think that's excellent. And there's a couple categories you touched on that hadn't occurred to me as fitting into public health. You also, like many of our members and our listeners, have extensive experience internationally. And for you, that means particularly in China. Can you tell us a little bit more about your experience there?
Yeah, sure. So indeed, I did live and work in China for 10, 12, 13, something like that years over the last, on and off over the last 30 years, working between Canada and China primarily. I've worked in Cambodia, training in Singapore, Hong Kong. So around the region, it's really been these two areas, Canada and Southeast Asia and China. I mean, my career started in rural and remote areas of Canada. And so that's where I was thinking first would be the distinction from classic urban family medicine, but then moved from that sense of rural to a more. I had a classic family practice first in Shanghai in the 2000s or so, retrained in public health as we've just discussed, and that global nature was increasing. Two parts to my work in Asia. First, 5, 6 years thereabouts, more in emergency management, and this was not the emergency of the individual per se, though there was that component. Sometimes I'd be jumping on a jet and accompanying somebody out of somewhere that they didn't really want to stay when after being injured. But a lot of it was also building on referral networks and pathways. That was one component, just to be for travelers and business folks and individuals like your listeners, to be
Yeah.
able to get them out. That was with one organization, and then I had the next 5 or so years more shifting into, and this was more sort of my career development, healthcare management and telehealth, and gradually shifting into supporting individuals who come to my quote unquote clinic, not through the front door, but through some benefits through organizations like yourself.
That is incredibly interesting because a disproportionate number of our members have experience with medevac situations,
Yeah.
including air ambulances, like you're talking about, and in some cases have relied on some of those referral networks to find a
Yeah.
provider. I'll say locally, but really globally in a in a local way.
Exactly. Which local one would I be most appropriately having confidence in? And some pre-established relationships. We'll undoubtedly talk about this as we go on. But you need to trust who's caring for
Yeah.
you, and having that, setting that up. So in both organizations that I work for currently with Teladoc Health, and there it was to be able to set up the Asia Pacific division, and so that was the last most recent 5 years in China, setting up there as the headquarters. And from there, I had, early heads up on some new emerging infectious disease that we're kind of talking about.
Well, speaking of infectious diseases, our listeners, you and I, all of us have lived through COVID-19. So I don't want to spend too much time going through the specifics or exactly what happened 3 years ago, but it was about 3 years ago, really in March of 2020, that we began to see a major impact on the lives of people across the United States. That impact had occurred earlier,
Mhm.
particularly in Asia, but spreading across Europe and so forth, prior to March 2020. And to date,
Yeah.
there have been over 700 million cases worldwide and almost 7 million deaths that have been attributed to COVID-19. You touched on this a little bit, but I'm hoping we go a little bit deeper. What
Mhm.
was and really continues to be the role of population health in this pandemic?
Yeah, it's so it affects a population. It's more than just one individual, and so it's taking that broader view, and population health touches on so many dimensions of, well, not just healthcare, but society, and how we go about our daily lives. We've all experienced it, as you say. We don't have to go into all the details, as you mentioned, though. Having being in Shanghai at the time, I had early warning, so to speak, and that's where having these networks that we've also talked about. I was just letting our medical directors around the globe, hey, guys, gals, ladies, gentlemen, there's something coming. Not sure what it is yet. And that was, January 6, 2020, that first put out a first memo, and phone starts ringing like crazy. But, the ongoing role, this has moved through various transitions where it seemed to be some kind of local epidemic. Now it's a little more than a small epidemic. It's now a whole city, and now it's a country, and gradually moved to, and all became familiar with certain terminology in the pandemic preparedness part of public health. And well, pandemic being multiple epidemics, if you will, across multiple regions, and that impacts how we can respond. You can't have, fire trucks from 3 cities come in, converge on one city, because they're all dealing with fires in their own cities at the same time. And so the ongoing support, is just to keep monitoring on the one hand, new variants are still popping up of this particular virus, COVID-19 being the disease coming from it, continuing monitoring, which ones should we be concerned about? Some are having more impact than others. But then we've also, and December, January, mostly December, just this past 2022 was probably the bigger one where, hey, it wasn't just about COVID. There was also, well, good old influenza, which has been around for a long time, and add a third one to make it a tridemic, or we can coin some new words as we go along. So that ongoing monitoring is crucial, that data piece and how you collect it. And that's been, a particularly interesting one in how you collect it, where we've been able to, what we saw during, I think H1N1 back at over a decade ago, one of the flu pandemics, and these flu pandemics occur every 10 to 50, 60 years. And, do we say we're overdue for another one? Sorry to burst the bubble, pandemics aren't gone. But where it started, where there were Google search term trends that were seen as early warning signs in different areas. We as an organization have clinical capacity in all 50 states and around the globe, and so this monitoring is a key bit. We could dig in a little further, and population health ties into patient safety, and patient safety, I think, is a key part where population health has an element of health equity and recognizing some populations are disproportionately affected, either wrong place, wrong time, or a variety of situations we don't always understand. Is it genetic? Is it socioeconomic? And understanding that. So, looking after patient safety without recognizing there are differences, that health equity piece comes up very importantly. And by just giving it a two-word name, health equity piece, I'm not trying to minimize it in any way. I think more and more of our organizations are recognizing, hey, identical response does not mean fair response. And, where do you adjust appropriately? It's a lot of place for public health, population health to work with so many collaborators. It's not just the public health professionals themselves who are got to do this. We can only do it well if we do it together.
Absolutely. And I feel like you've already answered this, but I just want to check, would you point to any specific public health lessons for all of us beyond what you've already shared?
Right. Well, one key lesson I think is, in terms of preparing for the next pandemic, and we have to keep doing that, it was, what kind of virus could it come? Where could it come from? How could it play out? The part that was not recognized, though it spreads similarly to a virus, is, could I say, misinformation and trust or lack of trust, and it's that communication piece. And that, I think we all got caught off guard to a degree, recognizing how crucial it is to have solid information, but more than solid information, trust. And that, I think there's enough blame to go around in every possible direction. There are ways we could have done better, whoever the we is, whoever's thinking through this and reflecting on this. So that's one lesson, the communication and the necessary either pre-established trust or the necessity of finding ways of establishing trust quickly, and in evolving situations sometimes has to be really quick, and that how to navigate communicating uncertainties. Don't pretend you know more than you do, and how to do that and still give confidence. So a few themes there: communication, trust, confidence. And then, as I mentioned, it's just providing, rapid response in different areas. Back in the H1N1 or the swine flu pandemic, I had the privilege of working with one of the CDCs in Canada, the BC CDC, and that was for building the plan for antiviral distribution at that time, as it were, for Indigenous communities, First Nation communities, and there, just having a plan isn't enough, and it has to be done in collaboration for that trust element. When there's history of lack of trust, got to work overtime to try and reestablish, get over. So a number of themes there, and I know that may be a little softer kind of things than we often think are needed. You need both, the hard medicine and the soft communication side.
Absolutely, and obviously we're here as that part of that softer side today, the communication. But no, I mean, that's incredibly important, because you've got to not only trust the messenger, but trust the message, and be able to receive it when it comes to that. But
Yeah, and then the message has to refer to something that is concrete thereafter. What do I do next? Where
Mhm.
do I go next? Who will come to me, and what are the next steps? All of those, yes, it's communication, but then there needs to be tangibles afterwards. Otherwise, it kind of definitely will fall flat.
Yeah, empower rather
Yeah,
than just yeah,
right.
inform.
Yeah,
Right.
empowerment, very good word. Well beyond the communication of the information, that people know how and what and where to do and how to help each other.
Right. Right. Well, we've talked about your international experience. You were in Shanghai when the
Hmm.
pandemic began and started to spread. And we're an
Hmm.
organization with a worldwide membership. And
Hmm.
I'm just curious, obviously staying away from anything political, anything like that.
Sure.
Are there are there any specific lessons that you see coming out of this for international healthcare or cooperation, collaboration among practitioners or
Hmm.
even among government agencies? And I
Okay.
don't want to get
Yeah.
you in trouble
No,
with anybody,
no
so
worries.
we can also
I'm
talk
speaking in my own
hypothetically.
words right
There
now,
we go.
but
Okay.
there we go. Preamble. I mean, first, small level bit is that can be translatable for, around is just having networks, having well, communication pathways, numbers and you can pick up. And there, for me, where I first lived it, I sort of knew this in principle from 10 years of working on pandemic preparedness a decade before, but then I had to apply it for what was then a small office in our global network of offices at Teladoc Health. And it was, okay, do I know on a map where all of my colleagues live? Physically, actually, with their numbers. And as things were closing down, I still wasn't being shut down, and I was distributing food to my colleagues.
Mm.
And so we're just going around the city, and then I happened to, I mean, all sorts of stories along there that I could open up and go further. But okay, each one of you try and make your way to the office. Here's 2 masks for each of you. It's all I would manage to find, but get a little bit 2 per family member actually. So
Mhm.
I cleared a few stores when I had been overseas when this broke and made my way back. But those same principles of networks and communication in the U.S., I know that my peers were both giving briefings at the White House, if you will. But let's step it back a little bit. And that's because of both the global part that we have the privilege of having in our organization, but also across the United States, and that working with the CDC, instead of Google search term trends, it was, what are we seeing in our, call it, online walk-in clinic. Now it's much more robust than it was 20 years ago and goes well beyond teleconsultations, but we were able to watch surveillance, some syndromic surveillance, looking at syndromes, anything respiratory, watching which states is this coming up. And so tying that information flow, a different kind of communication, data flows,
Yeah.
anonymized and everything, but to be able to say, we're seeing, keep your eyes on this state or on that state. And so those are the more intersectorial, government and private and healthcare and other kinds of responses. But back to the early days in January 2020, it was really between our medical directors around the globe. It was at some points daily briefings, and then calmed down a little bit. But then it came in waves, did it not? Waves. The word's been co-opted now.
Yeah, yeah. Well, and I appreciate, I mean, just some of the things you said today, the importance of networks, but also the work that you and many others have done on pandemic preparedness before we're facing the need for it. And be
Hmm.
able to activate those plans, that all of that's been incredibly important, and sharing that information through those networks.
Hmm. And I think a lot of people have learned these by necessity, and so we're not unique in that position. The big challenge is going to be these call it life cycles of
Mhm.
emergencies and windows of opportunity for emergency preparedness, and it's usually after an emergency. And you can think locally if there's been a fire, you could think a bit more regionally if there's been a flood. That people are, okay, let's make sure it doesn't take us by surprise next time. Because usually somewhere somehow there's a next time, but then there's a tiredness that sets in, and then and the news cycles will certainly go, and we need communication through all channels, not just networks, but through news and so forth. But they come and they go, and the pandemic preparedness, there's always, and other kinds of emergency preparedness more generally, sometimes you feel like you're calling out and saying, get ready for the next, and people are tired of hearing that, and sometimes you're like calling it out too much, it feels, and sometimes you're under calling it when everyone's panicking, and you're saying, no, it's okay, it's not that bad, and trying. Now this, it's not that we in emergency management have all the answers, but it's trying to be more even. And right now we're sort of getting, for a lot of people, past the window of being able to prepare for next time. But just because we're tired doesn't mean the next bug
it's going to wait.
isn't there. Is it around the
Right.
corner like a year, or is it around the corner 10 years? Don't know. I'd say we're going to see things well before 10 years again, and hopefully just regional, not pandemic. But we're in the endemic stage right now, where it's just there with us, and we have to learn how to live with it. That doesn't mean ignoring it.
Right. I think that's a really good takeaway. It's with us, we're living with it, but we can't ignore it, because I think a lot of us would like to.
Oh, I'd love to. I was so tired of pandemic preparedness after a decade working that space that I kind of let it go. And then when H7N9 came up, and then after then you had MERS, and then you had all sorts of different bugs. Okay, just talk with my public health colleagues in North America. I'm overseas. This is what I'm seeing. This is what I'm hearing. But those stayed regional, not pandemics. So the pandemic part is just that different nature of it.
Right. That makes sense. Well, one of the big changes that I've seen in the numbers for our health plan, and that I personally experienced, is the rapid adoption of telemedicine and telehealth. And I'm going to just use the term telehealth to incorporate both of those. They mean different things in our benefit structure. Different episode of this podcast to explain that. But in 2019, I think FSBP, our health plan, saw a few hundred claims, maybe not even 200 claims through our telehealth vendor. We switched in 2020. The plan switched to Teladoc. Yep. And I think that the utilization increased something like 3,000%. That may even be underselling a little bit, but I don't think that we are unique. So I'm curious if you can tell me a little bit more about what did you personally, or even Teladoc nationally and globally, experience in 2022, and how did you all handle the rapid increase in what I'm assuming was the rapid increase in
it
cases?
certainly was. It certainly was. And so I hadn't realized that we had just connected organizationally just prior to the pandemic, or just thereabouts.
Benefit change in January 2020.
Oh my goodness. Very interesting time. So we have been working in the telehealth, telemedicine, teleconsultation space since 2002. And so it took a decade to get to the first million cases, interactions, teleconsultations. But then things kind of have been going exponentially. And 2020 was certainly a time where we saw surges, and I think it went from in late 2019. I'm not 100% sure of the numbers, but we were kind of celebrating that we reached X number of cases per day. And good, the systems which were constantly strengthening to be able to handle high volume. Hey, we've hit 10,000 cases a day. I'm not making up, but I'm not sure of the precise number. But what I do know is over the course of 2020 and in the first half of 2020, now we're at 15,000 a day, 20,000 a day, and I'm told we hit somewhere around 30,000 a day. And the systems held, and you can imagine how there could be infrastructure issues, but to speak to volume, great increase there. And then that also took for us, okay, where are we going to draw in more doctors for, because this is a little more than your typical Tuesday afternoon. And so a lot of lessons continuously learned. It has to be a continuous quality improvement methodology on the one hand, but coming back to the utilization more from a member, a user, a patient perspective, you're right, across the board, an awareness of telehealth. For us, the first decade was just getting an understanding, well, not for us internally because we were living and breathing it, but to make sure that, from everywhere, from patients, from doctors, from regulators, that everybody understand that this is a means of delivering care. You can deliver care in the clinic, in the emergency room, you can deliver it through certain technology. Yet telehealth is so much more. And this is where I think there's been a gap in the last couple of years. A lot of people still think of telehealth as just this window through which you and I are talking right now. And there's so many other elements to it. But holding at that classic definition for a little bit. That's where we had opportunity across the 50 states with the CDCs, with medical directors of other organizations, just to keep exchanging on this. And that came to bear where we have command centers, virtual command centers, as it were, watching our trends in different areas and trying to predict, looking back over the last 48 or hours or 1 week, and project the next 48 hours. Do we need to call more doctors in, more practitioners, to be ready for where we think we're going? And this real-time predictions, and in all of that, building into the systems, make it easier to do the right thing. And if we've seen the last few months, AI, how it's kind of now having its takeoff moment.
Absolutely.
The trends, elements of this building in, machine learning, a little pre-AI, but building that in to facilitate. So it's fascinating watching how things take off like epidemics. Don't want to do too many air quotes, but behaviors and trends, sometimes there's this tipping point. We've been learning how to deal with that, and looking forward to being ready for the next times and grow from them.
Yeah. Well, and I'm just curious, because of our worldwide membership, and our benefit, where we've got access to Teladoc stateside, and also through program we term V-Health to Teladoc services worldwide. Did you all see any changes or expansion overseas?
Right, yes. And that some were already in the works, and some were very much by necessity reactive when it came to getting blurred on which year and which season. But India, when we saw a lot of cases in India, and then eventually came to the term the Delta variant, right? And there that was a tough time in many parts of the world. The particular variant started was seen in many places, but in India we had a huge surge in demand for our services by membership, and there had to stand up in very short order, because this went so fast, had to stand up teams. Some teams globally can be, while it's important because we have members there, can be a small team, 5 people. Sometimes it can be a large team. We have 100 on a network, or variable, but we had to stand up and create dedicated teams, and different teams crossing over jurisdictions, pitching a hand, and so a lot of internal collaboration. And then as a team gets ready to launch, then they're well established, and then build on that. So like most of our global teams, you start with one focus service, and so there was a pandemic response in using that particular example, but then you build laterally as other capacities are either needed or things calm down, and you don't want to take your eye off the ball, could be back, but build other services. So it tracked around the globe the impact related to the pandemic, which one came up at which time, and some had pre-established teams, others did not, but we've definitely coming out stronger for it. Give time to your people to rest here and there. Need to recover. Have different meanings of the word recover, but just the fatigue and all. But it's been an expansion. A lot of our expansion currently is moving also towards the hospital and health services space, and that's supporting and enabling existing health systems, not so much bringing our clinicians, but enabling them through our technologies and workflows and experience to be able to address a variety of areas. Virtual emergency departments, tele-ICU, and so forth. And then occasionally bringing surge capacity with the people. So all of these, some of them you can see tied closely to the pandemic, some more just general trends that are coming from greater awareness of telehealth.
Yeah, and in directions that we as consumers of telehealth might not even think about, but where that's playing a role.
Yes.
And to shift our conversation then maybe a little bit to focus more just sort of the telehealth experience, because while we've seen a huge increase, there are still some members out there who may not have engaged it, or who may not, when they have a need, may not think of telehealth as one of their options, or at least their first option. So you are a doctor, you have a background, as you mentioned, in family practice. From your perspective, are there advantages, and if so, what are they, in offering care through telehealth? And in all honesty, are there any limitations or drawbacks?
Mm-hmm. No, that's very good. Good question. And we have to recognize for any location or means of seeking care, what is the most appropriate venue for care? And telehealth, we could look at it as a form of a venue. Do you take care of your ear infection in the inpatient unit, in the emergency, in the outpatient or community clinic, or virtually online? Now, I started with one where, because not everyone is set up with an otoscope that is digitally linked, that I could see the ear from here, as I take the history, see how early on it is, what past history that individual has had with potential ear infections. I may give some guidance, or I may indicate you be seen in person, but then in many other areas, we see around 90%, and there's a certain self-selection that members will make. Just your members are smart and know where to go for a lot, but often, let me just, even as I was going to say, 92%, I think it is, of cases that are resolved in a first encounter.
Wow.
Even if it's emergent, I would ask members, just make your way to an emergency department. Now, that being said, I'm sitting in one place where I know what an emergency department means, but I also have lived in other places where it has a different meaning. And so sometimes it's just a quick conversation to get oriented and to confirm what I'm thinking. So I'm not inviting people to come to us if they have emergent conditions. Nonetheless, this conversation is crucial. So that broadens your classic thinking about, when do I go to the doctor? I go when I have a problem, and of this range. And so sometimes that range increases on both sides a little bit, depending on the area. I may have to say, no, that really is not something I can help with. You call your equivalent of 911, and we try and catch that prior to the conversation. But extending on the other side, 80–90% of health is outside of health care. And it's not just about the doctors or the nurse practitioners or physician assistants and other clinicians. So broadening our thinking there, if someone has chronic conditions, when you get 20 touch points, whether that be through a smart glucometer, if you have diabetes, and some digital coaching, and maybe a coach getting in, those touch points, the multiplicity of the touch points really empowers, back to a word that you brought up, which is so crucial. So I've taken telehealth, appropriateness, broader in some ways, but if I come back to that classic definition that most still understandably have, it's having, if it's a question about the skin, upload a high quality, good lighting picture that you can beforehand, and those kinds of things. Sounds like you've had other episodes on that. Where there are limitations, I would say those limitations are shrinking a little bit. On some of our platforms that we use, mostly the hospital ones currently, on this encounter, you could see, if you were the doctor side and I was the patient side, on your screen, think of it a bit of augmented reality. You would see a number giving my pulse, and a number, maybe my temperature, and a number, my respiratory rate, just getting it from what's being seen here, which for you and me, just going to be kind of hard to see the variation in the skin color to get the pulse. So some limitations of what we call physical exam are changing. I've been able, physical exam, doctors are embracing much more what can be done through these two dimensions. And, there's all sorts of articles, top neurologists, how to do, maybe I'm going to put the word as 70% neurology exam, where I can't test your sensation, but I can certainly do some other things. And neurology, I chose it because that's one of the trickier ones. Yet talking with some key neurologists at Mass General, hearing what they're saying and how they're shifting, and trying to guide their trainees to embrace, because this isn't going away. And then constantly triage is probably the biggest word, to jointly, in shared decision-making manner, patients and clinicians jointly triaging and deciding together, how far are we rightly going here? And for patient 1 and patient 2, patients have names, they don't have numbers, but recognizing it's not going to be the same decision every time. So acknowledge limitations, recognize they're shifting, but working together. we're back to communication and trust. How do you build trust in a few seconds with this barrier of a screen in front of us, which really, it doesn't feel the same, yet actually I feel like I'm connecting with you. We've gotten used to it in the last 3 years in a whole new way, that it feels like we're connecting, though when we're in person, I'll fully acknowledge it's another feeling.
Yeah.
So just because we get used to it doesn't mean we have to change what our goal, our North Star is of what connecting is, and safely guiding patients through their own healthcare.
I love that. Using the technology to improve these interactions, not replace them. I love
Yes.
that.
Hybrid care, it really has to, ideally you flip between both seamlessly, from the technology seamlessly. Accessibility, availability, transport is an area that is not as seamless. This is really convenient, but we can't be shy saying, look, this is not the way we need to interact for going forward. For at least one encounter, it has to be in person for reason X, Y, Z. Give a reason. Don't just say,
That's a good point too. Well, and you touched on the ways that telehealth access can improve access to care for people in rural areas. You talked about this early on, but also management of chronic conditions and so forth for outcomes. Are there other ways, looking where we are right now and into the future, and some of the ways that telehealth is playing a role in hospital care and so forth? But do you have thoughts on how health plans, individuals,
Yeah.
anybody can leverage access to telehealth to improve outcomes?
Yeah, it really goes to, if this is the if I'll call it consultations in person or virtually, so that hybrid care. If hybrid care, this part where there's a direct connection with a clinician is 20% of healthcare, is that 80%, it's enabling, strengthening self-care, if you will, but bringing in, I'm going to say non-licensed, and by non-licensed, I mean not doctors and nurses and so forth, but still very, very qualified and crucial elements of healthcare teams, coaches, health coaches. This is an area that's really growing a lot, that is so crucial. And other forms of communicating information, digital tools, educational, interactive, and what individuals can do at home, peer-to-peer, patient-to-patient, group medical appointments. We've been talking about it for decades, recognizing that peer-to-peer support, there's so many lessons learned that a patient living with, in a way that I'm not living with, or possibly not. Doctors have medical conditions as well, but that, a group of people, this is how I've gone through it, and this is how I'm working. And there's this opportunity now where the acceptance of new ways of, should I say, delivering healthcare or sharing in healthcare, are now acceptable to all of us, first as patients. And even the question, patient-centered care, it shouldn't be, we have to take care of our clinicians. If they burn out, we can't deliver care for this component.
Right.
But then let's say, because there was a book that say patients come second, and a lot of people took a fit, because that was just referring to, we have to take care of the healthcare workers. But now patient-centered care is crucial, but even the terminology, patient-centered, and some still kind of get riled up at this, at consumer-centric care. But we have to listen to those that we're serving. It needs to be a collaboration, and you can't collaborate if you're not listening. So getting together in that part. So group appointments, I think we're going to be seeing more of. And will we call them appointments or something else? I'm not sure. But then the data flow. How many of us are wearing something that has a lot of information about our health, and there's so many peripherals, that sensors you can put on that can monitor your stability of your gait. And so if I have an older parent, perhaps, and just to be able to recognize, all right, maybe some coaching on the physical activity, or not being too sedentary. And you might think that being inactive and being sedentary is the same thing. Actually, two different concepts that both of them have impact on cardiovascular health and or mortality, and is fascinating. So even if you get 150 minutes a week, better to look at 30 minutes a day than 150 a week. That's another theme of lifestyle medicine, if you will, little plug for you. But the sedentary bit, even for someone who, if you two people who get 150 minutes a week, and one is sitting an average of name how many hours a day, and the other a much lower number of days, different outcomes with the data that can come from various tools, and then the coaching, be it a reminder on your phone, on your watch, or with a call with a coach, all of these areas, these are what are next. This remote patient monitoring, but the P maybe even needs to change from patient to consumer, and I'm not even sure what the right word is going to be, but it's got to be together.
Right. It's fascinating. We'll have to, and you're right, it's everywhere. It's on our wrists, it's in our pocket with our phone.
So redefining primary care, we call it P360 in the Teladoc sphere, but redefining what that is and what that means, and how do we just monitor and take care and enable and strengthen and improve outcomes. And so we have to evaluate this as we go, and we're seeing really good signs. So yeah, the future is really exciting. Sometimes it feels, oh, it came too soon. I just want to be able to benefit from all this, but actually we're you and I, we get to talk about and actually co-create this.
Right. You a little bit more than me, I'm glad to say.
Well, as a voice,
right,
you're a voice for many people, and yeah, we're going to carry that conversation on.
Absolutely. Yeah. Well, but so and we're coming to the end of our time. So before we wrap up, though, is there anything that we missed today, or anything that you'd like to add to what we've discussed?
Let me, you might say, I do like granular, but I like big thinking at the same time. And the thing is that teleconsultations and broadening that in this especially this international space, I think is interesting. One thing, let me say, that came up beyond the health equity piece, and that's recognizing that your listeners are in a whole bunch of different locations, and it's not all the same access that they have to various services. Here is one through Teladoc Health that they all have access to, and that's great. And so there's a similarity between all, but beyond that equity bit, that in so many areas is an area where I'm just trying to actually reorient to a degree my own career path, and just recognizing the importance. Another one that is similar to that is environmental sustainability. And the reason I bring it up in this context, I was doing a boot camp on environmental sustainability not a week ago, and then someone beside me, and then we started crunching some numbers on carbon footprint, and then recognizing that we were between 100-fold and 800-fold. There's a range there, difference. So let's take the more conservative one, say 100-fold difference, that 100 times less carbon footprint for a virtual consult than an in-person physical consult. And then we're starting scratching our heads, what does that mean? And, of course, patient safety first, of where you go and how you go and what you serve. But when you think of it, if somebody's going to travel, 10 hours to visit a specialist for 5 minutes, not every encounter with the specialist needs to be in person. So that was a whole other area when you talk about the future that we're looking at. So the conversations are very broad, and recognizing what are the important conversations. So thank you so much for bringing me in to join you today, for recognizing that the experience of your members in so many countries is so varied, where we can help give them a little piece of some of the lessons that we've learned over time, which I know they've all learned a whole lot of lessons, that we can share those and grow from it, and be better and stronger from it. But here to be there with them, a little taste of familiarity now it's familiar, that we can just, be a touch point, that they not be shy in reaching out and say, yeah, maybe that's earlier than you ever would have seen a doctor in the past, because you know what to look for. But quick touch point, 5-minute conversation. If you have peace of mind from that, awesome. Right. We just want to help you get unstuck and have a better sense of next step. So all the best to you, what you're doing.
Thank you very much, and I so appreciate you joining us today, and the work that you and your colleagues are doing to support our members around the world. So thank you very much, Dr. Foggin.
It's such a pleasure. Thank you, Kyle.
Foreign Service Benefit Plan members can learn more about telemedicine coverage and access to Teladoc and vHealth telehealth services at AFSPA.org/FSVP, or by reading the plan brochure. This has been AFSPA Talks, a production of the American Foreign Service Protective Association. The views and the opinions shared on this podcast by the host and guests are theirs alone and do not necessarily represent AFSPA or any of its partners. All information offered in this podcast is meant to be educational. Should there be any discrepancy between information offered in the podcast and official plan documents for the Foreign Service Benefit Plan or the other products offered by AFSPA, the policy provisions will prevail. Thanks for listening, and be sure to subscribe to AFSPA Talks to catch our next episode. Please rate and review us on your favorite podcast app and share feedback with us on Facebook, Instagram, or LinkedIn. Search for @AFSPA Cares. I'll talk to you again soon.
Thanks for joining us this week on AFSPA Talks. Be sure to subscribe to our channel so you'll never miss an episode. If you have any follow-up questions about the topics in this episode, join our AFSPA Live Q&A session on the last Thursday of every month. We will be streaming live on our YouTube channel at youtube.com/AFSPA Cares at 11 a.m. Eastern Time to answer your questions. Thanks for listening.